Alright, so this is my extra credit video. I'm going to be doing case 2, which is Mr. P. We do have some crazy cats right now, so please ignore any cats. So Mr. P is a 55-year-old male post-op, day 1 following gallbladder removal. The surgery was uncomplicated, but he is still complaining of some moderate right-sided abdominal pain with any movement and coughing. However, the cough, there's no cough, no sputum, and no wheezing. He hasn't been out of bed yet, and prior to the surgery, he was short of breath with just normal household activities. Currently, he's just slumped into the bed with a JP drain on the right abdomen and compression stockings on. I'm going to go through a little quick screen of what I'm going to anticipate is the results, and then I will go through what I did with the patient. So what I see first is I'm looking at the patient's past medical history. We do know that the patient is obese with a BMI above 40. Obesity could be causing his obstructive sleep apnea. So we should be concerned about the sleep apnea because it leads to decreased gas exchange. The patient could end up being hypoxemia, hypoxemic, and hypercapnia, which can lead to things like cardiac arrhythmias, changes in cardiac output, and cerebral perfusion, leading to MI, heart failure, and stroke. The obesity can also cause those gallstones, which could have led to the gallbladder needing to be removed. We also know that obesity can cause hypertension too, and the patient has that as well. Obesity can also lead to cardiomyopathy, so we might need to worry about the patient eventually having cardiac heart failure. And then his triglycerides are high, and his HDLs are less than 40, and his diastolic blood pressure is greater than 85. So it also looks like he qualifies for metabolic syndrome, which again has increased risk for cardiovascular disease. He also has asthma, which is an obstructive lung disease. So all of these comorbidities themselves definitely warrants a complete cardiopulmonary exam. Next, we're just going to take a look at those medications. So we know he's on capoten, which is an ACE inhibitor. So we need to really worry about muscle cramps and dizziness with that one. And then Zocor, which is a statin to decrease lipids. That can cause hepatotoxicity and muscle weakness, not related to exercise. We need to be aware of that too. And then he's on metformin, which is glucose regulation for hypoglycemia. So we might want to be monitoring any signs and symptoms of hypoglycemia. And then we have 2 bronchodilators, and with those, we will look for any tachycardia and dizziness. We also know that he is on morphine, so we need to watch for he's going to be kind of tired, dizzy, and respiratory depressed and sedative functions. So then we would jump right into the screen. So we would do a quick intake screen, just look at that incision on the right side. It does say in the prompt that it is dry and clean, so nothing to worry about there. We would do a cardiopulm screen looking at blood pressure. We could expect to see high blood pressure because the patient is hypertensive, but they are on an ACE inhibitor, which does work to decrease blood pressure. So it might be normal there, so we just need to be aware of that. We could see some tachycardia with the heart rate just because of those bronchodilators. Respiratory rate, we know that the patient is not in respiratory distress, so it could be normal. However, the patient could be taking more shallow breaths just because they're avoiding really taking in those deep breaths, because it could kind of add pressure onto that incision. So we should be looking for that. Also with the morphine, that can cause respiratory sedation too. So just be aware of that. And then SpO2, since they're not in any respiratory distress and it doesn't look like they're on any oxygen, we would hopefully see the SpO2 at least in the normal range. We're going to move on to our neuro screen, and with our neuro screen, we would expect things to be normal. This isn't a neuro patient, but we would still make sure to check sensation and balance, but we would hopefully expect at least sensation to be normal. Balance could be impaired when we get the patient up. We'll just have to see. MSK, we would assume the patient has full passive range of motion. We could expect some movements to cause a little bit of pain if it's stretching the skin right there, but it should be full range of motion. We might expect to see definitely some lower extremity weakness, just because the patient was having some limitations in movement before and not really moving around a lot due to the shortness of breath. So we could expect them to have weakness, probably both upper extremity and lower extremity. And we would want to make sure to do both lung and heart auscultations. We want to do the heart auscultations just because the patient has hypertension. So we might expect to see an S4 heart sound, just because sometimes with hypertension they can get that too. So we want to be aware of that. And then with this patient, they also have asthma, so we want to make sure to listen to the lungs. We could expect some wheezes. However, it was noted in the case that there was no wheezing, but still we should be checking that. We want to do a cough assessment. I know it does cause the patient pain to cough, but it's necessary to do, so try to do it quick. We could expect the cough to be weaker than normal, just because tightening those ab muscles increases the pressure inside the abdomen, which could irritate that scar and that wound, so might be weak because of that. We want to palpate the muscles of inspiration and expiration, just because the patient does have asthma, which is an obstructive lung condition. We don't know how bad the asthma is, but it's definitely something we should check. We also know that patient may be taking in more shallow breaths due to the surgery, so we should just be aware of that. Immediate percussion, we should definitely do it, but we wouldn't expect to hear any different sounds than normal, just because there's no consolidation in the lungs right now. It's just the asthma, but it's definitely a good thing to check. And then we could look at diaphragmatic excursion, and we would expect that to be normal. However, it could be a little bit decreased, just because the patient may not be taking in those full deep breaths because of the pain. And then we're going to do a quick activity evaluation. Maybe some things, just getting the patient upright first is a big thing, and getting them up, checking their balance, and then performing maybe 5 times sit to stand to look at functional strength and endurance there. And then hopefully gait. If the patient can tolerate a 6-minute walk test, might be helpful too. But with that, we're just going to expect a decreased endurance, a little bit of muscle weakness. We talked about that before, and then probably will have shortness of breath, since that's what they were having before. So we definitely need to remember to monitor SpO2 while we're doing any sort of activities, and should probably monitor blood pressure too, since we are worried about that hypertension. Yeah, so that's what we would do with that. And we would teach the patient, or plan to teach the patient, some pursed lift breathing, just because the shortness of breath, it's good to get in the breathing that way. And then since the patient is wearing those compression stockings, we might be worried about a DVT, so we could be talking to the patient about that risk and just how movement is going to help. So that's the summary of what I would expect to find, and then I will start the actual procedure now. Alright, so I've already gotten consent for my patient to treat him, and so we're going to move straight into our systems review. First thing I'm going to do is I'm going to do a quick intake screen, and then I would look for lines. We know he has a JP tube going on, and then we know he has an incision on his right side, so I'm just going to check that really quick. So I'm just going to check your incision right here. Good, so we know that is clean and dry. And the next thing we're going to do is a quick cardio palm screen. So I'm going to take his blood pressure, heart rate, SpO2, and respiratory rate, and then we'll listen to his heart. Once we get him sitting up, we will also listen to his lungs. Alright, so I'm going to take your blood pressure. What we're going to do now is we're just going to put this cup around your arm. Alright, it's going to squeeze just a little bit on your blood pressure. And while that's happening, we're going to put this on your other hand. This is going to take your heart rate for us, and then your oxygen too. So that's going to go through. Let him just rest down. And is it okay if I roll up your sleeve? Okay. deep breaths and stay quiet while I take your blood pressure. Alright, so my patient's blood pressure is perfectly normal. With this patient, we could expect to see normal blood pressure like we talked about before because of the ACE inhibitors, but could also be elevated because of the hypertension. And then his heart rate was 58 and his oxygen percentage was 95%, so that's normal for him. Like we said before, we could expect to see some tachycardia due to the medications, and we would expect SpO2 to be okay since the patient wasn't in any respiratory distress, and right now the patient is just sitting on the bed. Alright, so now we're going to test this patient's sensation. We would expect it to be intact since this isn't a neuromuscular issue, but it's always good to check, especially when we're getting the patient up and moving. Alright, so we're going to use this cotton ball to test just light touch sensation. What I'm going to do first is I'm going to take it and we're going to touch your cheek. That'll be kind of our baseline. Then I'm going to touch it to different parts of your body, and I want you to tell me if it's the same or different, okay? Okay, so this is the baseline. Alright, close your eyes and tell me same or different.
Same. 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 Same.
Alright, so this patient's sensation is intact, which would be expected. So the next thing we're going to move on to is a quick MSK screen. We would expect this patient's MSK screen to have normal range of motion. However, we would expect some decreased strength just because this patient was pretty sedentary and just had surgery. Okay, so what I'm going to have you do is I'm going to have you reach your arms up and overhead. Perfect. Bring them back down to about halfway. Good. I'm going to put some resistance down on you. Hold, don't let me move you, okay? Hold, hold, hold. Good. The other side, hold, hold, hold. Good. Can you give me a bicep curl for me? Perfect. Hold, hold, hold. Hold right there. Hold, hold, hold. Push into my hands. Push, push, push. Good. And then can you grab my finger? Good. Good. Okay. Now, can you bring your toes up towards your head? Okay. Hold it there. Hold, hold, hold. Good. Hold, hold, hold. So I'm going to keep you draped all the way to the cat. Okay, what I'm going to have you do now is I'm going to have you slide your heel up towards your butt like you're bending your knee. Good. I want you to hold it there. Hold, hold, hold. Good. Push into my hand. Push, push, push. Good. And we'll do that same thing on the other side. Drag that heel up towards your butt. Perfect. Hold, hold, hold. Push, push, push. Alright, and actually back to this side. Can we bring that heel up towards your butt again? And then your knee up towards your chest. So like you're bending at your hip. Hold, hold, hold. Good, relax. Let's do that same thing on the other side. Hold, hold, hold. Relax. Alright, so this patient's MSK screen was fine. However, ours, we would expect that they would have some lower extremity weakness and possibly some upper extremity weakness. My body mechanics would also be a little better if I could get onto the other side of the bed, but unfortunately, this bed is a little bit too big and the wall's too close to down this side. But that would be it for our screen. So what we're going to do now is we're going to get the patient up and sitting, and we are going to listen to their lungs and their heart and test their sitting balance. Okay. So, what we're going to have you do is we're going to take away this pillow now. I know movement with that incision is a little bit painful, but you were strong enough to push up. So if I could have you just push up onto your elbows first, and then onto your hands, and we're going to pivot so your feet are hanging off the edge of the bed. Perfect. So, what we're going to do now is we are going to give your heart a listen to. There are 5 places I'm going to listen to on your heart. 2 right here, 1 right here, and another one right there, and then 1 kind of underneath your pec, okay? Are you okay with all of that?
Yes.
Perfect. So, what I'm going to have you do is we are going to just untie or unbutton your gown. Perfect. Just like that. The first 2 places are right here. Are you okay if I palpate to find them? Okay, perfect. And I'm just going to listen to the other side of my skull. Okay, then the next 2 spots are kind of right in the middle. Other side. And the last one we're going to get to is we're going to kind of go underneath your sleeve. It's going to be right over there, okay? Let's button you back up. Right underneath your pec muscle. Good. Alright, so now we're going to give your lungs a listen to. You do have asthma. We might expect to hear some wheezing. So there are 8 points I need to get to on your chest. There will be 2 kind of above your clavicle, 2 right below it, 1 kind of in between your pecs, and then 1 out to this, or 2 out to the side over here. Okay? Are you okay with all of that? Okay, good. So again, unbutton the skin. Okay, and while I'm doing this, I'm gonna have you take deep breaths in through your mouth and out through your mouth. Okay, and go at your pace. Ready whenever you are. Okay. Ready? Okay, so the last 2 spots are again kind of way out on your rib cage right here. So I'm just going to go through your sleeves on both sides. Deep breath in whenever you're ready. Just a second. Alright, so that is the end of our auscultations of both the lungs and the heart. So again, we could expect to see an S4 heart sound due to the patient having hypertension, and we could hear some wheezes because of the asthma. Alright, so the next thing we're going to do is a quick cough assessment. We are going to test the strength of the cough and see if there's any sputum. So, can I have you give me a good strong cough? Good. Okay, so we would expect the patient to have kind of a weaker cough because they did just have surgery near their abdomen, and coughing can increase that intra-abdominal pressure, which would be painful. So that was expected. Next thing we're going to do is we're going to palpate. So what that means is I'm going to be looking to see how much movement we get of the diaphragm. Do the shoulders come up? Look at the movement of the ribs here, and then underneath the scapula. Okay, so what I'm going to do is I'm going to put my hands over both of your shoulders, and you're just going to take a deep breath in for me, and I'm going to note the rise and fall of your chest. Okay? Good. Now I'm going to come kind of underneath your ribs right here, and we're going to do that same thing. And deep breath in for me. Okay, and now I'm going to come into your back, and we're going to do that same thing again. Okay, take a deep breath in. Okay, and then while we're in this seated position, we would also check balance here. We know he's good statically balanced, but we would also check dynamic balance too. We can have him reach up and touch my hand. Good, over here. Good, now I'm going to give you some small pushes. Try not to let me move you. Okay, good. So we tested anticipatory and reactive balance. Okay, so now we're going to move on to immediate percussion. This is going to be done on the patient's back, just giving it some quick taps. So what I'm going to do now is I'm going to test the sound that your lungs make. I'm going to do that by, I'm just kind of tapping my finger along your back, okay?
Okay.
Okay. So, I'm going to go at each intercostal space. Just going to give a tap. Alright, and then we would continue down through the whole way, and now we're going to test for diaphragmatic excursion. So I found the place on the bottom where the sound starts to change. So now I'm going to have the patient take in a deep breath and hold it, and then we're going to test down to see how much farther it goes, okay? So take a deep breath in, hold it in. Good. Okay, good. So we would measure that distance there. For this patient, it would be normal. However, for our patient in this case, we could expect to see decrease just because the patient doesn't want to take in a nice big breath because it might hurt that incision to take a deep breath. But yeah, there was that one. Okay, so the last thing we're going to do is some activity and some functional stuff. So I'm going to get the patient up, but I'm going to make sure I put on my gait belt first. Have you ever had a gait belt before? Okay, so you know the drill. It's going to just go around your middle. Make sure I have extra control just in case you were to fall, but I don't anticipate you falling. Make sure it's nice and snug, but not over your incision. So what we're going to do is we're going to stand up now. So I'm going to have you scoot as far as you can to the edge of the bed. Tuck your feet back as far as possible with your heels still on the ground. Have both hands on the edge to help you push up. I'm going to stand in front of you to help you stand, okay? Actually, the first thing we're going to do is can you just push off with your hands and your legs and lift your butt about a little. Yeah, perfect. And the next thing, now we're going to do the standing thing, okay? And I'm going to help you. So we're going to rock forward 3 times, and then on the count of 3, we're going to stand, okay? So 1, 2, 3. Alright, so once in standing, we're going to make sure the patient feels safe. We can assess their balance here, and then we can do like an egress test. So what we're going to do now is we're going to march. So we're going to lift one leg up, and then the other leg up, and we're going to do it 3 times on each foot. Good, good. And then we're going to take some steps forward. So let's step up, perfect, yep. And then the next foot, good. Next foot, good. One more time, nice. Perfect. So we've assessed that the patient is stable and able to move away from the bed, but we are going to do a quick 5-second sit to stand to just test their functional strength. So can I have you take a seat back down? You can reach back with one hand and slowly lower back down. Okay, since I know you can stand by yourself, what we're going to do now is we're going to do a 5-time sit to stand test. So we're going to have your hands across your chest. You're going to stand up and down as fast as you can 5 times, okay? But not too fast that you feel unsafe, okay? And we will start whenever we are ready, okay? So whenever you're ready, you'll set a timer. Okay, 1, good, 2, good, 3, 4. Good, now sit back down. 5. Perfect. So we did that. With our patient, we might expect to see some shortness of breath, and it would take longer than the average time just because they were already experiencing shortness of breath and limitations in activity before coming into the hospital. And then we could also have the patient do some like a 6-minute walk test or other sort of sub-max endurance testing, expecting all of those to be decreased, so abnormal, and could need to take frequent breaks and have shortness of breath. Perfect. Okay, so just some notes about this case. We would make sure that we were auscultating on the skin. In this case, we just did it over his shirt. I would probably make sure that the gait belt is on and the patient's balance was tested before I started moving around and testing immediate percussion and that sort of thing. And then also we would really want to make sure that the gait belt wasn't around his incision. Just because of the height difference, I can't put the gait belt over his or underneath his axilla because I could not reach it properly. But other than that, that was it for the case, and thank you.